Welcome to this online CPD training with the content around low back health. We also use the term low back pain. However, this holistic view to understanding why our clients may hurt in their back area should be taken for more of the principles around understanding movement issues relating to modern ailments. So if you make yourself comfortable, grab yourself a drink, maybe a notepad, and I'm going to take you through the PowerPoint and some of the background. I'm just going to share my screen with you now. My name is Rachel France, and my 30 years around movement started with professional dance, but I'm also a sports massage therapist. I Move Freely program director, a strength coach, and I have a special interest in intrinsic biomechanics. So as a master trainer, I take great satisfaction from trying to simplify very complex human movement issues. And that's what we're going to be talking about through this session today, is understanding some of the details around particularly our clients' back problems and health. So we're going to begin with spinal anatomy. We're going to look at clinical conditions and also around pain science, which I've got some recommendations on some books. So you can make some notes on those. Now, how we can help clients manage that, but understanding what pain is, what it isn't, and the different sort of terms that come under the umbrella of pain to allow us to understand our remit. We're also going to be discussing government policies and sort of authorities that you may want to look at within your borough, your area, your field, to understand better about the legalities and the requirements, responsibilities that you may have as a movement or massage practitioner. I'm going to be talking about duty of care, which is a huge issue with regards to all of those things I've just mentioned, but also coming into GDPR data protection, particularly more so now that our industry is becoming more online, even as a service provision. Communication skills have been amplified in certain ways where we may not have used this online variation previously to help clients. So we really need to hone in on those communication skills. We're going to be talking about epidemiology, risks, symptoms, psychosocial factors, evaluation tools, and also models of behaviour change. As I mentioned earlier, what we need to keep into the focus of our of our minds really is the body works as an integrated system. And so other programs that we teach, we'll talk about different body parts, different areas, the substructures. But I think through any of our programs, our ethos is that the whole body works together. We may feel a pain in the shoulder that is caused by something in the opposite side of the pelvis, for example. Between those two areas, we do have the back. And so while we are going to be studying detailed spine anatomy, I would strongly recommend that you look at some of our other programs, or certainly more details around pelvis, shoulder, knee, and foot biomechanics. The idea at the end of this session is that we should be able to agree, design, and implement a physical activity program that can help patients or clients, depending on your remit, who experience low back pain. It's understanding how to deliver, review, and then adapt a physical activity program that will allow us to provide a duty of care and also help our clients move more freely and hopefully reduce their back pain. So we're going to start by looking at the detailed picture of a lumbar vertebrae. So the lumbar spine, obviously in the lower back area. And what you can see here is on the left-hand side of the slide, there is an axial overhead view of a single lumbar vertebrae. And then to the right of that, there's a lateral or side view. Over on the right-hand side, what you can see is, again, that overhead or axial view, but with some definitions of areas in there. So you'll see that you've got the vertebral body, which is the big circular area, and that is really the kind of more solid, robust area that we think of in terms of the way the spine stacks on top of itself. So each vertebrae stacks on top of each other. You can see there that you've got the cortical rim around the edge, which has a more solid colour to it than the centerpiece, which is where the spinal discs will sit. The idea being that is where there is more room for force absorption or shock absorption, if you like, with the cortical rim being a stiffer area for support. What you can see is also there is a vertebral foramen or foramen, depending on how you want to prefer that, pronounce that. And that is where your spinal cord will travel through. And it's made up of two pedicles, which come from the vertebral body, and then they meet two lamina. So the pedicles and the lamina create basically the foramen, which is the name for a hole within inside or an opening within inside the body. And they are key to encasing the spinal cord. What you can see coming off the bottom on that right-hand image is a spinous process. And if you felt down the kind of spiny bumps of your client's spine or your own spine, you would feel each of those spiny processes as you go down. That is ultimately a land site for pulleys of muscles and soft tissue to create movement through the spine. In that case, kind of spinal extension, maybe some rotation as well. Off to the side, you've got the two transverse processes. Again, they are muscle attachment sites, and they are key to the attachments for muscles we talk about, like quadratus lumborum or the psoas muscles in some of our other workshops, and how they attach onto these sites and create movement like lateral flexion of the spine or even spinal flexion through the sagittal plane. And then you've got what's described on that PowerPoint as a superior articular process. Now it's superior because it is the top portion of the landmark on this particular vertebrae, but it will make up a joint known as a facet joint when it meets with the inferior articular process of the vertebra above. So as the two areas come together, the superior articular process of the lower vertebrae, the inferior articular process of the vertebra above will approximate with it, create a facet joint, and the facet joint's key role in spinal anatomy and movement is a movement limiter. So that's important to understand in relation to movements like lateral flexion, when there is dysfunction of the quadratus lumborum, creating a hinge, and then through rotation or movement, flexion, extension, lateral flexion, there could be a point where there is more or less movement within that area, and then the facet joints are at risk of degrading or eroding. Now, the reason they're limiting movement is, of course, because we have those soft tissues in between, we have the discs, and we also have that spinal cord. So those movement limiters are really important to maintain their robust structure, and understanding how muscles will influence that area is a key component of what we do as movement professionals. So here we're looking at the ranges through the lumbar spine. Over on the left-hand side, there's a description of the joints from S1 up to L1. And then you've got flexion, extension, side bend, and rotation degrees of movement through each of those joints. So what you'll see here with the lumbar vertebrae, there is more range or scope for the lumbar vertebrae to perform through flexion in the sagittal plane than any of the others. Because the lumbar vertebrae begin in extension in terms of our natural lordotic curve, they have more scope for flexion. So we often think about spine flexion as a bad thing, particularly in the lumbar spine. However, each joint has the capacity for quite a big range of lumbar flexion versus any of the other motions. And if we think of why that might be, we think of sitting down on our haunches, squatting down with our bottom down close to our heels, which is a natural sort of caveman squat, if you like, then the pelvis will tilt backwards, forcing the spine into flexion. That's not necessarily a bad thing. However, in the exercise world, when we're adding loads, like a squat bar across the top of the shoulders, that's going to change the force, or the compressive force, going down through the lumbar spine, and that is where flexion is deemed probably not the best place to have a load sort of going through. In this slide, we're going to look at the contrast of the thoracic vertebrae, and probably the most dramatic thing we notice is the reduction in the size of the vertebral body. Because it's higher up the spine, there is less load going through it, then we don't need such a big vertebral body. There's still a cortical rim, there's still the foramen, there's still two pedicles, and there are still lamina that make up that foramen hole where the spinal cord will pass through, or the vertebral foramen. What you can see here, the transverse costal facet, which is where the transverse process coming off the side has a sort of facet or a smooth area on it. And at that point, we would have contact with a rib. And as it travels forwards or medial, you can see on the vertebral body, there is a superior costal facet. So the rib would attach to both of those sites. So it does have two attachment sites before it comes around the organs, around the lungs, and to the front of the body, which would be at the top of the view of this image, into the sternum. So you can see where the ribs can affect movement through the thoracic spine potentially, or vice versa. We've still got a superior articular facet, but what you can see here is the angling is quite different to that of the lumbar vertebrae. And when we start to look at the ranges through the thoracic spine, again, we've got the joints labelled over on the left-hand side, so L1 right up to C7 are included in here, and the norms for ranges through flexion, extension, side bend, and rotation. And if we add up those ranges, what you will see is the thoracic spine has most scope or range through rotation, which is the last column on the right hand side. My video may just be covering that slightly. So when we think about movement and rotation, certainly compared to, just go back to the lumbar spine, where only 3 to 4 degrees of rotation at each joint is expected as a norm, when we look at the thoracic spine, there's obviously an increase. And so you've got this comparison between the different areas of the spine to understand, when watching your clients moving, probably where we'd expect more or less movement to come from through each of the ranges. So again, when we look at our movement testing in some of our other workshops, we have a test for thoracic rotation, which would fix the pelvis, fix the scapula, and hopefully show us at least what the spine is capable of through rotation. From a visual perspective, we expect through that test around about 45 degrees of rotation. What you can see here is the spine from L1 through to C7 should be capable of around 57, 58 degrees. And so expecting 45 isn't a huge amount, but what you might find if you do tests like that for thoracic rotation is that very often a common issue we see is a lack of thoracic rotation mobility. So you can pause the video just now. You can take out a pen and paper. Then what I ask you to do is just move my PowerPoint video up and out of the way and bring that back, see if you can see that there. And so what you've got here on the PowerPoint is sort of a sketch or cartoon version of the vertebrae as we just looked at them. You've got the words to add on to the numbers, so the lamina, the vertebral body. Just fill in the gaps there on the text if you can't see it. The superior articular facet, pedicles, transverse process, and the spinous process. So what you can do now, as you pause the video, is next to number 1, 2, etc., write down what you think is the relevant terminology for that part of the body, the vertebral body. So welcome back. Hopefully you felt confident with that. You can obviously check back through the video and check if your answers are correct. Just a little something to add into our thinking. So now we're looking at the sacroiliac joint, and we can see the pelvis on that left-hand side of the PowerPoint. And on the right-hand side, you can see how it's been cut, so we can see some of the portions within it. Now, the sacroiliac joint is where the sacrum and the ilium will meet. And it's through that joint that we expect some degree of movement to occur through the gait cycle and other movements. Different pelvis will have different angling and flares and geometry around this joint. And that's something for us as exercise professionals to be mindful of when we're asking clients to move in certain ways. An example might be somebody with a very good geometry or genetic geometry of their sacroiliac joint, but poor muscle tone may still have an unstable pelvis. Somebody with poor geometry but good muscle tone may be able to stable their pelvis quite well. However, if we have a client who has poor geometry and poor muscle tone, then there's probably going to be some work to do. Now, there are certain things like geometry of the sacroiliac joint that are going to be very hard to test from our skills as exercise professionals. And we often understand that certain people will move different to others of our clients. So we need to just be mindful when we're asking clients to do things like squatting, for example, that we allow them to position the feet where it feels most comfortable, rather than simply in a geometry that may have been coached for a different body type, which may feel less comfortable for them. Obviously, we can vary foot widths, different squatting types and depths, speeds, and so on. But I think taking into account there is going to be a natural structural geometry that's inside us that we cannot really change. As exercise professionals, being aware of that might step us up a little way in terms of allowing clients to kind of move in the way that they feel comfortable, position themselves so it feels comfortable. There may also be some natural slight asymmetries, so our focus may be less on symmetry and more around function and good quality, comfortable movement. So what we can see here is the ligamentum flavum. And what we've done, as you can see from that image, there's a little square at the bottom of the vertebral body. We've actually cut away the body of the vertebrae. So we're now looking into, or posterior into, the cavity where the spinous processes are ahead of us, the transverse processes off to the side. So we're looking into the back of the spine. By removing the vertebral body, what we can see is the ligamentum flavum sitting at the back there. So the spinal cord will pass over the top of that ligament. That ligament is going to be responsible for assisting with the limiter. So here we can see ligamentum flavum. And so what we've done with the vertebral body, if you look at the bottom image, you can see the overhead view of an entire vertebrae. We've cut away the vertebral body and we're now looking into the cavity of the spinal column. So you can imagine the spinous processes moving away from us, ahead. Behind those ligamentum flavum, the transverse processes off to the right. And over the top, as we look at that ligamentum flavum, over the top of it would be the spinal cord. As we look at it from the side view, so we've sliced down the center of a vertebral body, and you can see the spinous processes going off to the right. We're looking in the left-hand side, if you like, and at the inside of the right half. To the left-hand side of that cutaway image, you can see the vertebral body, the intervertebral discs, and at the top there, the anterior longitudinal ligament. Right down at the bottom, you can see the posterior longitudinal ligament has been labeled, and their role really is in limiting extension and flexion. So the anterior ligament will limit extension, posterior will limit flexion. Ligamentum flavum at the back there, you can see, again, just to the right of posterior longitudinal ligament, you can see the the spinous processes, and in between those, the interspinous ligaments. And as you can see from those fiber directions of those interspinous ligaments, they're deliberately off at an angle to allow some degree of movement, but limit too much. Now we're looking at, if you imagine slicing, again, looking down at the image at the bottom there on the PowerPoint, slicing away the spinous processes, the transverse process. So we're looking at the back of the vertebral body. We can now see a different view of that posterior longitudinal ligament. And what you can see here is how it's almost hugging around, where you can see those kind of arms coming off it to the sides. It's almost hugging around the discs there, the spinal discs. And it's going to play a big role in keeping those discs nicely in place so that they do not impede upon the spinal cord and through to the spinal nerves. So we might see on MRI scans, and we're going to certainly look at some later on, where the posterior longitudinal ligament may thicken, hypertrophy, or deform as it's trying to limit any pressure coming from the discs for a variety of reasons, but predominantly we're interested as movement professionals in reducing loads like heavy loads through the spine that are asymmetrical, or again, we could talk about muscles that attach to it like quadratus lumborum, or the hip flexors or the psoas, for example, to understand how much force they're going to apply maybe anteriorly to the vertebral body, which could put pressure backwards onto the discs, which again could stress the posterior longitudinal ligament. So it's quite interesting when we understand the anatomy, the terminology, and understand what could happen if our clients don't improve their movement under our care. Here we are moving into the rib section, and what we've got here is obviously a full rib. And you can see the costal groove. There's the body there, which is predominantly the main portion of the rib. There are tubercles where you can see that it would attach onto that thoracic vertebra we looked at earlier. There was those two facet areas. You've got the neck, the head, and the key part here is that angle over on the left-hand side. For any manual therapists who are in a position to use manual articulations, we can use very gentle sort of grade 1 or 2 pressure on that angle to mobilize, if you like, the joints, the facet joints where the ribs attach onto the thoracic vertebrae. So it's quite an interesting way to look at the anatomy and understand how pressures can affect both positively and negatively how we feel and how we move. What I'd like you to do now is if you just sit up in your chair, and you may be able to watch me in the little video clip there as well, ribs 1 to 5. So if you place your hand across the top of where you can imagine your ribs 1 to 5, what we're going to do here is feel the movement of the ribs when we take a breath. So that the upper ribs, the most superior ribs, if you take a breath in and exhale, there's almost like a pump action to those ribs. If we come down to 6 to 10 ribs, so if you imagine putting your the scoop of your thumb to first finger under your armpit and your palm around the upper chest underneath the armpit, take a breath here. We can feel almost like the action of a bucket handle on either side. And then when we come down to the last sort of 2 ribs, or floating ribs, if you like, we take a breath. There's kind of a flare where we want more movement as we come lower down, and that's where we want to be breathing, is down into the belly. So again, just understanding there are slight differences in the ribs and the way they flare, pump, or move like a bucket handle in terms of how we breathe. Looking at the discs here, this is images from Kapanji's work, and we can sort of identify, obviously, the A and the N will stand for the annulus and the nucleus. So understanding how the layers of the annulus coming in form, and what you can see from the bottom right hand sort of representation there are the layers that we're imagining of the annulus. And you can see the fiber directions, they kind of cross fiber as they lay on top of each other around about 45 degrees. And this again allows for some degree of movement, but will also limit movement around this area. We also talk here a little bit about nociception and nociceptors. So where we might have an understanding of proprioceptors or proprioception, which is senses or receptors of where your body is in space. We might relate that to balance, for example. Nociceptors are known as pain receptors or messaging receptors. And so we are thought potentially to have nociceptors around these areas. And one hypothesis is that some people may have more or less than others, so they feel more or less pain than someone else, but also that some people may have a real focused number of nociceptors around the outer edge of that nucleus, annulus. Now this little image here represents what's known, certainly in the clinical world, as a degenerative cascade. So on the right hand side, we're going to start at muscle spasm. So maybe we're sitting, we're watching this, we should be moving a little bit more, hopefully you're wriggling around a little bit like I am. And we might, the body might compensate for a lack of movement and create an adaptation within the muscles, like QL, which create what's known as subclinical muscle spasm. So before we actually get really uncomfortable, we may just stiffen up a little bit in that area. What that can do, if the muscle goes into what's known as subclinical spasm, it can decrease the vertebral space. And so what that then does, it reduces the fluid being pumped through that area, which can result in a decrease in the height of the disc, which means the ligaments on either side become lax. And what that can result in is those facet joints we talked about earlier will approximate or become closer together, which could result in an adaptation within the muscle. And so what you can see is there's this otherwise maybe known as a vicious cycle, but a degenerative cascade. So as exercise or movement professionals, the part that we're really interested in is the muscle area, which we can actually take tension off, either by helping the pelvis move well, the shoulders move better, or maybe even, if we think it's safe, to release the QL muscle, again with exercise, movement-based remedial techniques and or manual therapy, to hopefully improve what's happening, increase the blood flow, increase the tension in the ligaments, and hopefully improve movement overall, as well as intrinsic physical health. So here we're looking at the spinal cord and the relation it has with the sort of nerve roots, the vertebrae, and the way we form. So we often think about the human body as a fantastic piece of evolution, and it's well designed. And this is where I guess we let our body down, because the spine, the osseous sort of structures within the spine actually grow quicker than the nervous system. And what you can see as we look at the spinal cord, if you like, now it's shown here, it's represented in colours. So you can see the green represents the cervical section, blue for thoracic, kind of a maroon purpley colour for the lumbar area, and red for the sacral sort of coccygeal areas, or where the nerve, the spinal cord nerve parts are within the spinal cord. Coming off those, you can see to the right, in relation to the vertebral bodies, are the sort of nerves that relate to the spinal cord, or the peripheral nerves coming away from that spinal cord. And as you come lower down, what you can see is they kind of get stretched down almost into areas that you wouldn't necessarily associate in this sort of image, if you like, with the area of the spinal cord. So you might look, for example, at the L5 nerve root coming down, low down and below, but you can see where it relates to the lumbar spinal cord portion much higher up. It's almost like it's been stretched down. And what you can see there is another, just some sort of language and vocabulary, is the sort of what's known as the cauda equina, which is also the name for a really serious medical condition that we should be mindful of in terms of the symptoms, signs and symptoms, which is bilateral pins and needles through the lower limbs, loss of bladder control as 2 examples. Certainly go and have a look and research it. And it's known as cauda equina because equine relates to horses, and this is the horse's tail, like it's represented through those kind of spinal nerve roots, if you like. Here, just a brief image at the spinal membranes and roots. And the reason we want to talk about this is just simply because spine mobility improves the mobility of the nerve roots as well. So while we think of, for example, a spinal rotation motion affecting the joints of the spine and improving rotation there, a key component here when we get into the nervous system is the nerve roots. So we need to think of smaller ranges to begin with, moving slowly and tentatively, get those nerve roots mobile so that when we get into the more gross movements, then the bigger nerve pathways are prepared for that. So in this next section, what I'm going to ask you to do is a little bit of research. So you can pause the video in a moment, and I'm going to ask you to take some time to just go and research some of these terminologies. The idea being, if we can equip ourselves with great resources online that are sound and robust to find definitions of terminologies, we can better help and educate our clients alongside our clinical peers, clinician peers. So I'd like you to take these words down on a piece of paper or have them handy on another device, research them, interpret them in detail so that you could explain or define them should a client come to you and ask, what does edema mean, or conus, or arthrosis? So this isn't about us being clinicians. We shouldn't be stepping over our remit, but we can certainly help our clients understand some of these may be perfectly normal and what they mean, and being able to give an explanation about whether we would actually work with somebody who have any of these conditions. We need to understand what they actually mean for us. So while you're doing some research, I'd like to just make a note next to them about whether you would work with them, we feel you'd want to work with them, and if you did, what would you need to consider? So I'll let you pause the video and then I'll see you in a moment. So on this next task, what I'm going to ask you to do is to, again, pause the video. You're going to have a look at this MRI scan, and using the techniques you learnt just a moment ago by stopping, hopefully, the video, going and doing the research task is exactly the same thing, but this time with a genuine document that was given as an MRI report written out, detailing what they had discovered from the MRI to be able to offer this patient's clinical support network an understanding of how to work with them. So what I'd like to do is go down, for example, the first line, C5, C6. There is a mild central disc osteophytic bar. There is no central or foraminal compromise. What does that mean? What are the definitions? What does foraminal mean? What does osteophytic bar mean? And then each sentence as you go down, writing next to it whether it has ever any concern, whether it relates to movement, do you think, in terms of will it inhibit movement, do you think? And then when you get to the bottom again, you're going to decide in your own sort of time, would you work with this person? And if so, what, how, why? And in what way may you need to modify their program? I'm going to ask you to do the same for this next one. And also we have one more. Okay, so we'll run through some of these sentences. So hopefully what you found when you did your research was that there is probably nothing to worry too much about as we run down mild central disc, osteophytic bar. Osteophytic bar is a bony growth or spur, but it's saying there's no central foraminal compromise. There's no compromise to that gap or that the center of the foramen. The rest of the cervical disc is degenerate, but there's no protrusion, so they're ruling things out here. T2 to T5 are the same, a small central disc protrusion, but there's no central foraminal compromise. So what that's now telling us is there's a little bit of pressure at the center there, but actually that posterior longitudinal ligament sounds like it's doing its job. T6-7, there is a small central disc protrusion, but again, no nerve root compromise. And in the lumbar spine, L3-4, the disc is degenerate with a small central protrusion and an annular fissure. Did you get annular fissure? So that is a crack. A fissure is a crack of the annulus. So that's probably a risk. It's a risk. It's something waiting to happen, but there's no central or foraminal compromise. But there's obviously some pressure on that area of the disc that's noted with this fissure. So in terms of our movement prescription, we might want to be getting the pelvis and the shoulders moving well to take pressure off the spine there. L4-5, degenerative discs, again, small central disc protrusion, but no nerve, root or central compromise. And really, degenerative disc is a normal part of aging. The rest of the spine disc, lumbar discs are normal, and there's a normal conus lying at L1. A conus is a cone-shaped end to the spinal nerves, and that's at L1. And so where that cone shape, the area of the spine that is cone shaped, known as a conus, it's saying it's totally normal. Just be mindful that the term conus also relates to one of the chambers within the heart. So if you see that on a different report relates to the cardiovascular system, just so you know that it's the same writing of the word, it's just a different part of the body. Normal cord and cranio-cervical junction, normal bone marrow signal apart from end plate changes. So the bone marrow signal is obviously the weight coming from the MRI scan that shows the signal in a certain light, but it is showing us there's end plate changes, so the end plates of the vertebrae. No normal facet joints and no pars defects. So did you look at pars defects? So a pars actually in true sort of definition is just a part or a portion, and a defect is a problem, but a pars defect is normally related to the process of the spinous process, and there's a break. More commonly with teenage athletes who hyperextend and rotate very quickly like a bowler in cricket. So just being mindful of that. But here there's showing no defect. So up to now, really this MRI has been ruling things out. Sounds okay. There's a bit of pressure where there's that annular fissure, but hopefully we can help them move better by getting the pelvis and the shoulders moving at this point. But the conclusion states there is multi-level degenerative disc disease, but there's no central foraminal compromise, so there's no concern. However, when we come to the MRI of the sacrum and the coccyx, there is a mild subchondral edema and sclerosis of the iliac side of the right sacroiliac joint. So subchondral means a cartilage below the area is sort of, there's a mild sort of excess of fluid, which is the oedema portion. Sclerosis, again, is like a toughening or a stiffening of the joint, which is normal aging, and it's on the right side of the iliac side, so the ilia, that is actually showing the sclerosis. The articular surface is irregular, which again confirms that sort of sclerosis, and that might mean that the movement around that side of the hip is more limited or stiffer, maybe by comparison to the other side, or certainly maybe with another client and the way they move. There is a mild sclerosis with the left sacroiliac joint, so similar again, best seen, and then it's giving a sort of a weight or a description of an MRI image. The rest of the bone marrow signal is normal and no stress response. There is a retroverted uterus. So I'm not sure if you had a look at that terminology. Retroverted means it's tipped backwards. Retroversion can relate to other things like driving back, a backward gait, which is a normal gait. But in this case, it's a uterus that's tilted backwards, which may possibly, depending on the degree of tilt, affect movement, or when we're testing someone's pelvis function, it may affect that a little bit. It may not at all either, but we may or may not know this. If we've got this scan, then we would, obviously. And the ovaries are normal, so we know it's a female. So the conclusion is there is a mild asymmetrical sacroiliitis. So by the end of this, maybe you got to the point where you said, do you know what? Sounds like they might need some of my help. But the biggest red flag here is a lack of information for us. We don't have the client, we don't understand their pain or the reason for them getting this scan, which is usually pain related, or certainly if there was any loss of function. But there's nothing here that's a huge red flag in the description alone. Clearly, when we're working with clients, we would be working with their therapists, their clinicians, their physios, their GPs, and whoever else is involved in their care. So we would have more information. But just from reading this alone, just for the purposes of this project here, to help us as movement professionals understand a little bit, maybe coming from an MRI that might put the fear of God into a client, it helps us help them understand it a little bit better. So together with their radiologists, their surgeons, then we would collectively be able to reassure them, actually, this isn't too bad. Some of those words may seem scary, but I'm going to help you improve your movement with this guidance from these clinicians. So moving on to the second MRI scan. So again, this is, again, I'd like you to pause the video, take a moment, research the descriptions, and then I'll come back and we can discuss it. So coming back now, hopefully you're back from the pause. Did you pause? And so what we're looking at here is a completely different report written about the MRI scan. And the first area, the magnetic resonance imaging of the lumbar spine, MRI is the description there, the definition, gives a technique which is the plane films of the lumbar spine in lateral projection. Only inflection and extension are available for reading. So it's just describing the technique used for this MRI scan. The findings state there is a significant underpenetration of L5 to S1 intervertebral level on both views. So there's some ambiguity in the way the radiologist has written this in terms of significant underpenetration and the definition of what that means. So again, we're quite limited in only having this information. So clearly we would, if we were working with somebody, have their description of why they had the MRI, the report or more detail coming from the radiologist and their surgeon, so that we can then work with them. But again, there's the way some things may be written could in English grammar be deemed slightly ambiguous. So having the words significant and under next to each other could sound like a contradiction, unless under is the kind of superior portion or below. But again, that's not for us to decide. We would want to go back, talk to the radiologist or the surgeon, or get the information from them about exactly what is this saying. However, it looks like it's playing it down, significantly under penetration, intervertebral level on both views. But as we read on, what we might decide is a bit more about what that's telling us. The alignment of the proximal lumbar spine is anatomic. anatomic is really about just anatomic neutral. If we think about sort of where we take movement descriptions from, that sort of normal anatomical position. However, the relationship at L5S1 cannot be accurately ascertained on these views. So they're actually struggling to understand from the views that this MRI has taken exactly what's going on with the relationship at L5S1. However, they can see a slight narrowing involving L4-5 level, but the central canal and lateral neural foramina are showing on this study to appear patent or free of compromise. Patent means unremarkable. So again, it's a good chance that you may have got to the end of this and thought, well, it sounds like they're not sure, but everything sounds okay. And again, we would agree with that. However, with the caveat that obviously if we had received this, we would want more information from the client's clinical team to understand how we should work with them in terms of our movement skills. And finally, coming into the third MRI scan, I'm going to ask you again, if you can just pause this video, and I'll be back in a moment. Welcome back. So what did you find? So did you decide you would work with this client or not? Well, let's explore what's written here. And again, we've got initially the first paragraph is about technique. And again, the descriptives in there, sort of 1.5 Tesla MRI scanner is the piece of equipment used. You've got T1 fast spin echo and axial T2 fast spin echo. Again, it's talking about imaging, the angle of the imaging, the type of imaging. And so that's really not for us to worry too much about. That is really for the radiologists or the surgeons to communicate with each other, the understanding for them on how the imaging was done, performed, and at what speeds and weights and angles and everything else. So what we're interested in is the findings. So the normal lumbar lordosis is maintained, and there is an increased T1 signal intensity at the sacrum, which can be correlated with a history of radiation therapy to the pelvis. So the T1 signal here is more about, again, that technique rather than the T1 spine. It is a description in the way I understand this sentence about the intensity of the signal in T1 through the certain plane rather than the thoracic spine. But what we've deemed from this is this client clearly has had some radiotherapy looking like it was at the pelvis area. So we might understand or want to know more about the reason for that. Could be cancer related, for example, and we would obviously have that information, or hopefully have that information. At the T12 vertebral body, so we're now talking about the T-spine as the definition terms there, anterior wedging and approximately 30% anterior vertebral body height loss. And it says it's unchanged and suggestive of a partial compression fracture. So let's just take that apart for a moment. So anterior wedging would mean that the front of the vertebral body is kind of reduced. So there's a wedge shape to it, and it's reduced by about 30% here in the vertebral body height loss. However, it's stating that it's unchanged since possibly a previous scan, but it is suggestive of a partial compression fracture. So when that loss of height occurs, you can get sort of breaking compression fractures where the vertebral body has been squashed or deformed, and so there's appearance of fractures or fissures, if you like, through that area. At T12 L1 level, the central canal as well as the bilateral neural foramina are patent, so unremarkable, nothing to worry about. At the L1-2 level, the intervertebral disc demonstrates a loss of signal intensity as well as a slight loss of the disc height. So again, possibly normal degeneration, but the central canal as well as the bilateral neural foramina are patent, so again, unremarkable. L1-2 level invertebral discs demonstrate a block broad base posterior disc bulge, that's a mouthful there, measuring approximately 2 millimeters. Now, this is obviously where we're getting some pressure, posterior disc bulge of 2 millimeters. That's not for us to decide whether that's extreme or not. We would want to confer, but that's now starting to get a little bit more cautious for us terms of movement practice, whether we would work with this individual. Facet arthrosis, so if you imagine those facet joints where the vertebral bodies come next to each other, they are movement limiters. If there's some arthrosis there, it is mild, that could in fact influence their movement and of course their comfort levels in those areas. If there's some arthrosis, which again is normal aging, but again it might impact on their movement. Right foraminal narrowing is mild, central canal narrowing is minimal, and left neural foraminal narrowing is minimal. So mild, minimal. How do we know what these mean? They sound kind of not so bad, but actually we're now getting some compromises that we want to be aware of. Does this impact on how they're feeling, how they're moving? We would certainly want to start really communicating with their clinical practitioners. L3, vertebral body demonstrates approximately 30% vertebral body height loss, suggesting a partial compression fracture, again unchanged. So a bit similar to our previous sentence with the same wording. L3 to 4 level, there is a loss of disc signal intensity as well as disc height. So again, possibly normal aging. There is a broad-based posterior as well as a bilateral disc bulge. So again, we're getting this bulging and this pressure, and it's bulging into the far right lateral recess. So far right lateral recess, that's kind of like an area or an opening measuring approximately 3 millimeters. Now this may be again where our posterior longitudinal ligament is diverting the bulge, which is a good thing. We don't want that pressure coming straight back onto the spinal cord. Bulging posteriorly measures around 3 mil. Okay, well, it may be starting to struggle at this point, and we may be starting to be concerned about whether we work with this individual. Facet arthrosis again, and here we've got the ligamentum flavum hypertrophying at a moderate level. So again, that ligamentum flavum is really trying to hold on or hold back by the sound of it, because it's thickening, it's hypertrophied, and it's a moderate level as opposed to minimal or mild. The right neural foramen, so the right nerve hole or gap, demonstrates moderate narrowing, and the central canal demonstrates mild narrowing. I'm not sure the difference between moderate and mild, maybe open to debate, but again, ambiguity in language may be seen here. And the left neural foramen demonstrates mild narrowing. So we may want some definitions and some understanding of what this might mean. At the L4-5 level, there is evidence of significant compression fracture and infiltration involving up to 90% of the L5 vertebral body height. Okay, we're really concerned now. This is really huge red flags now. So previously we were like, oh, it's not looking good. We wouldn't necessarily say that to a client, but there is some retropulsion. Retropulsion, remember that driving back into the central canal measuring 6 millimeters. Now, 2 mil, we may be, I'm not so sure about that. 6 mil sounds like we would probably be avoiding working with this client already. There is also a bulging into the left lateral recess. Yes, the left lateral recess by approximately 3 mil. Facet arthrosis again, and hypertrophy. So hypertrophy of the facet, really not a good thing. Moderate to severe. So the language is now becoming more extreme. Right neural foraminal narrowing is moderate, and central canal narrowing is moderate to severe. And the left neural foraminal narrowing is minimal. I hope at this point you sent this client away. Good. Okay. So yeah, by the end of this, we really don't want to be working with this client. We want to be sending them back to their clinical friends and asking them to help the client understand this better. So be careful about describing these things to the client. We don't want any fear factor or any psychological detriment to their movement capacity, but we do definitely want to be trying to communicate with their clinical practitioners. So this slide is really just to raise awareness that a percentage of abnormal findings on lumbar spine, MRIs and CT images, and these are in healthy, pain-free subjects. What you can see on the left-hand side are their ages from their 20s up to their 80s. And then what you can see color coding is the ages where they were shown to have disc degeneration, disc bulges, disc protrusions, facet degeneration, spondylolisthesis. And so these guys had no symptoms. So you can see even down in the 20s, there were some of these issues, particularly disc degeneration is, you know, quite prevalent in sort of between 25 to 50% of, you know, 20 somethings to 30 somethings. So there's often a fear related to some of this language. Oh my gosh, I've got a disc bulge, and yet the correlation with an MRI and how they feel doesn't always translate. So people can feel great and have an image that says they, you know, they have bulges, they have all sorts of things going on, or they can have, you know, there can be an absolute agony with actually quite subtle changes. So we're finding that pain doesn't always relate to degeneration or abnormal findings. So it's quite an interesting concept that the MRI scan could itself create the problem by somebody feeling like they can't move, and then they actually get worse as a result of it. Just going to come across, come back in. Apologies there, I got a little bit stuck. So this is another task for you. So I've got a couple of slides, and I'm going to get you to pause the video again in just a moment. So we're going to be looking at clinical conditions. And the idea is to be able to research and define one to all of these conditions listed here, and note the implications and adaptations that you might make in terms of the exercise prescription for a client. The idea is for us to be able to explain by preparing a suitable kind of way of describing what's going on for them, maybe in a leaflet or a bullet points or images or drawings, so they don't feel too much fear about movement, because quite a few of these, as you'll probably find out if you do when you do your research, can actually benefit from movement. The body is designed to move. We just need to help them move it in a way that they feel comfortable, safe, and obviously aren't too much in pain for it. So what you're going to do is, I'm just going to show you the second slide. Put the condition name down. You can use this, you can print this off, use this as a template, or you can write it down on a notebook. What is it? What causes it? What might you see? What might the client feel? How would we explain it to them? How would it affect the exercises they do? And then the picture just means how might you draw a cartoon or a kind of a variation to describe what they're feeling. So you can go between this slide and this slide for that task, and I'll see you back here. Welcome back. So the next section we're going to be looking at is an introduction to pain science. So what I'd like you to do is take this link. I'm not going to play this. I'm going to get you to go and play this in your own time. I'm just going to show you. I'd like you to go and have a look at Jack with Peter O'Sullivan before we begin. So I'm just going to ask you to with me, and I'll show you what I would like you to look at. See if I can do it this way. So hopefully you can see this video here. Okay, Jack with Peter O'Sullivan, November the 7th, 2012, and then come back in a moment. Are we back? Okay. Share my screen. Bring the PowerPoint back up. So how was that video? Was that interesting for you? I think when we look at it in terms of understanding pain, there are really two people that come to mind for me, certainly when we talk about this introduction to pain, what pain is, and obviously Peter O'Sullivan did a great job there with Jack, purely from a psychological intervention to understanding his pain, helped him feel better. So there is a book called Explain Pain that was written by a Mr. Lorimer Moseley, Dr. Lorimer Moseley, and David Butler, shown here. So Lorimer Moseley on the right, David Butler on the left. And they wrote this book. They are now known as world leaders in neuroscience, very modern, and they're still adding to their research. There's some fantastic books, and I think Explain Pain is probably one of my top 3 favorite books of all time as a movement practitioner. What this particular edition or version of their interpretation of pain does really well is it helps both the practitioner, us, and the client who read it understand it better. So they've written it in relatively lay language. They have upgraded it more recently with an Explain Pain Supercharged, which is quite technical, let me warn you. But I actually really like the Explain Pain one for me. Anything that keeps it nice and simple. You can also head back over to YouTube at some point at the end of this lecture to watch their videos. Lorimer Moseley is certainly a charismatic presenter, quite humorous. So I think you'll enjoy those. What I talk about is the fact that pain is normal, but it's very often misunderstood. And certainly when you get a client coming back, their road to recovery, helping them understand it, their expectation that they would just start to feel better may have been confused a little bit with the idea, well, actually, in the real world, you might feel better, and then you feel worse again, and then you feel better, and it's kind of this up and down and zigzagging journey towards feeling better. Well, what is pain then? What is it if it's normal? Why do we have it? Why do we experience pain? Well, pain is an alarm, and what the brain does is it perceives danger or the threat of it, and the brain is going to listen to signals from the body about the heat or pressure, and it evaluates what they might mean. So pain is not a damage indicator necessarily. It can be, obviously. So what we need to understand is that when we have experience of trauma, pain is good. It's telling us we actually need to get out of the way, move our hand, change something. There's a problem. But if it persists, if it goes on for too long, it's not very good at telling us how bad and where if the pain persists. It's that persistent pain, the messaging or the link becomes kind of weak. So there are cases where individuals have had no pain, but a huge amount of damage. So you can see from this image here, that looks pretty daunting to have what looks like a screw or a nail in the head. And so obviously there's no pain message. This guy, my understanding was an Illinois man lucky to be alive after accidentally shooting himself in the head with a nail gun. Now apparently he managed to do it because it dropped, I think, if you read the article. But he just went in, he carried on his work, walked into the hospital, and they did the scan, and it was, that's what they saw. And then also a guy who got shot in the head 5 years ago, hadn't realised it, thought there was kind of like just a tap to the head. But it's again about this messaging system. It can be weakened in terms of its accuracy, and certainly the sort of level of pain that we feel may not represent the amount of damage or the risk. You've also got the idea of amputation, or our military folk who come back from the war with amputations, and they still feel or experience phantom limb. It may itch, or they may get sensations in a foot that is no longer there. So the limb is itching, it's tender, or it needs a scratch, and that can be really frustrating. But it helps us to understand that pain is an input, not an output. So it isn't about necessarily indicative of damage or what's going on, but the messaging that we're getting may become faulty. So amputees can experience all sorts of sensations in a missing limb. And after injury, this might also happen that you're left with a fear of a certain movement or an area of the body still gets kind of that feeling in it, even though there is no longer any pathology there. So pain is more about protection and sensitivity rather than necessarily the actual trauma, certainly if it's persistent. So hurt does not equal harm. Pain or persistent pain is more about being super sensitive. Pain is really about a protection mode. So thinking about pain and the way it changes our functions, we could also think of it on a neural perspective, and the messaging becomes dysfunctional or faulty or oversensitized, but also the fact that the messaging may interfere with what's happening in terms of muscle function, balance, strength, coordination, but not only mechanically in terms of the way we move, but also in terms of our endocrine system, hormonal systems, stress levels, cortisol, etc. So we can get a real sensitivity where the body's trying to heal itself, it's gone into this protection mode, and we may get all sorts of indicators. But it's really about the amplification of the process. So really, how we feel pain is relative to the sensitivity when it's chronic or long-term. That's more likely to be the kind of client that we might work with. So your nociceptors, if you remember those from earlier when we were looking at the spinal anatomy, they have that danger reception, sends a message to the brain decides whether to turn the pain up or the dial up or turn it down. So that would indicate we could do one or the other through cognitive type therapy. So what are you saying is all in my head? Well, no, but yes. So what we're looking at here are emotional changes as well. So understanding we can often come across clients who experience a frustration in being told, well, it's all in your head, and they feel like they're being told that it's not true, and that's not actually the case. They might be feeling that somebody's telling them that it's in their imagination, but pain is actually real. If they feel it, then it's there. So the practitioner's job, part of our role, is to educate and help clients to understand exactly what it is and what's going on. Our job is really to support and help create that positive learning environment, motivational interviewing about what they can do. We're going to talk a little bit more about that later on in this lecture. But what we don't know yet is how depression, anxiety may catastrophize and relate to pain, or which one comes first. We just know that they're related. Do they cause pain, or the result of pain when you feel depression or anxiety? So common occurrences to have changes in our emotional state with pain can come from being more depressed, feeling more anxious, we feel more sensitive, we feel more pain. And you may remember or recall that type of thing. Now, persistent pain, and there are some terminologies I'm going to use here. I'm just going to move my video across a little bit. I feel like I'm just in the way of the PowerPoint. See if that's helpful. Bring it back. So persistent pain, there are neurotags that become more easily activated or sensitive to movement. So a neurotag, like a nerve tag, tags on. And so neurotags can couple with other neurotags for movement, thoughts, emotions, and beliefs. So even just the idea of going to the dentist may result in you feel, sensations around the jaw. And so clients who have back pain, for example, may, if they just sit in a chair, they start to hurt. And yet if they sit on the sofa, it doesn't feel so bad, maybe. But coupling of these neurotags with an emotion make reporting the danger easier, so the pain comes about more easily. And so neurotag studies, or understanding how they become active when they wouldn't normally, it's called smudging. So the messaging becomes smudged. Quite like that term. So for us, really, what we're talking about here is how we can help a client understand how this smudging or this transference of an emotional experience can activate the neurotags, give us some sensations like discomfort or tenderness or pain or tingle. And this can spread or be not specific or move around, and they don't understand that. Actually, if it's moving around, that's probably a good sign, or potentially a good sign, if it's not a focused point of pain. So the brain creates pain for many factors, and really different people, different pain, but they can have similar injuries. So there's always this thing you see on the internet where people are researching, yeah, I've got a sore shoulder, it's around the front, I feel it here. Someone else, oh yeah, me too. We need to be mindful of not using sensation really as the guider. So pain can change from day to day. So how we feel, how much sleep we've had, our emotional state as well. And actually stress can increase pain. You may kind of think of a moment when that's happened. Shoulders come up, you're like, oh, you want to get into a fetal position. So pain can fluctuate when you're sick. You can be more mardy, sensitive, susceptible to aches and discomforts. I'm sure you're all familiar with that. And pain can differ depending on where you are. So as I mentioned earlier, being in the chair or actually sitting on a beach in a deck chair, you may feel fine, but it's still very similar or the same posture. So it's understanding how they all fit together and result in what our client is experiencing. So also understanding the ties, as I've said earlier, with experiences. And we don't really want to be avoiding the dentist, but we want to understand it. And just that understanding alone, that cognitive, therapeutic, sort of rational discussion could reduce or hopefully omit completely the idea of getting sore teeth just thinking about going to the dentist. It's all about context. So you imagine being a violinist or a cello player and you damage your fingers, there is a good chance you might feel more pain than somebody who doesn't use their fingers in such a dexterous sense because of the value that's there. It's been shown that you can have a more, or it's been recognized that you can have more areas of the brain light up or develop based on your activity. Like a violinist, the brain has a larger area dedicated specifically to the fingers. So that then creates the extra sensitivity there. So it's understanding with clients and when they're moving, recognizing that chronic pain in relation to back pain, how much movement is okay, and of course they may have extra areas of the brain related to that area, and can we help them understand it to reduce the sensitivity. So not necessarily they're damaged, they may be just sensitive, and so this is what we can help them with. Now this great image comes from the Explain Pain book. So what you can see here is two mountain tops before injury, and then the other one is after injury. You've got the lines of protection by pain to avoid the tissue damage, which comes at a slightly higher area. But then after injury, you've got this new point where the pain kicks in much lower down or much earlier, and possibly a new tissue tolerance area, again, if you've had an injury previously. So understanding that the pain may kick in much sooner because you're trying to protect the area that was hurt so that you can then avoid that point where the tissue may well start to break down again. It's the idea of maybe if you hurt your back when you're out digging and then anything bending over gives you pain, when it's not actually the act of bending over, it's the memory of that actually happening when you're out doing the digging or the gardening. So what can we do? Well, there is something or a technique known in the clinical world called graded exposure. So what we can use is understanding from a scoring scale, I'm going to show you next, that over time we start to expose our client to slow, safe, gradual movements that they can tolerate so that their brain starts to recognize that it's safe. And we can start to nudge them towards certain levels of, let's classify them as discomfort. And I think also this comes into our communication skills when we talk about those later, when we use them with the client to convert them out of thinking in pain, using the word pain, describing it as pain, when actually it may just be more of a discomfort, which doesn't sound or feel, excuse the pun, so traumatic. So what we've got is the idea of breaking this cycle, calming the system down and helping them move differently while in pain. So how much discomfort or pain is okay? We've got like a variation on the scale here, like the Borg scale, 1 to 10 on comfort or discomfort. So down 1 to 4, the green area is I'm okay, feel fine. 5 to 6 is about being careful, the yellow segment. 7, 8, 9, 10, back off. That's too much. And we might consider this not just at the time, but also monitor them after certain moves or exercises or new programs that we've given them. And if they get a flare up, then we know we need to back them off again. So it's just having a coaching cue we can use when we ask a client, let me know how it feels from 1 to 10 when you do this. And if they're within those first areas, then we're good. There are also some myths out there about don't slouch, don't sit with your legs crossed, don't work sitting all of the time, avoid certain postures, when actually each of these are perfectly fine. It's the variation or the duration. So that's the problem. If you just sit for long periods, which is why I'm encouraging you to have lots of breaks from this lecture and for myself, so we can have a move around, a little break in between, then the variety means we keep the tissues healthy. We've not just got that big gravitational force on our bottom from sitting, for example, and actually no posture is a bad one. It feels okay, it's relevant, and it feels good for us. Some other myths might be around knock knees or flat feet or leg length discrepancies cause pain. These are all normal variations for some demographics. So if we say to somebody, you have a leg length discrepancy, that could be detrimental to their psychology around long leg, knee pain on that side, for example. So we need to be very careful about how we translate what we're being told and what we understand about anomalies in our physical presentations. It's also the idea that joints are out of alignment and need to be clicked back. This is completely false. So again, I think some interpretations of what's happening when a clinician manipulates joints, they may have tried to put things into a lay terminology, or the client may well have interpreted it as a clicking because that's what it sounded or felt like. Technically, that is not what's happening. And then you've got the idea of x-rays. Remember we talked about them earlier, and that everyone over the age of 20 will have, there's a good chance, will have degenerative changes. So we've always got to be mindful about an MRI or a scan or something coming back saying dehydrated discs, any of the things we looked at earlier, that is why you've got the pain. Because there's often times where a surgeon's gone in, done some surgery to remove maybe a bony spur or something, and actually the client's come out with the same pain. So clearly that prominence that was assumed to cause it, in those cases wasn't the case. Sometimes it is, but just to be aware that sometimes it isn't. So just the references from that pain section here, just for a moment, to let you know, were taken from The Sensitive Nervous System, which was written in 2000 by David Butler, and then obviously the Explain Pain book, which was 2013, and then Supercharged more recently in 2017. And also the PowerPoint was put together by Mike Grice of Movement Therapy Clinics and Movement Therapy Education. So it's important that we as practitioners help clients to understand their pain with a good back consultation. So what does that mean? Well, it means asking them questions about their pain. So their experience of chronic pain, whether it fluctuates, what makes it feel better, what makes it feel worse, how it's affected their life, will all contribute to a good motivational interview or experience for them. Somebody's actually wanting to know how they feel. So in terms of as a coach, again, if and when you are hands-on with a client, we must be mindful of human touch in terms of chronic pain clients, they may have a fear of somebody moving them, and that in itself could make them feel worse. It's important that we explain what and why we make decisions, things are going on, what we find, our opinion, and we can use models and posters and drawings and screening forms and links men to just demonstrate and show them not only what's going wrong, but maybe what's really good and healthy about your findings. It's also key to help us show them that we understand how it may be affecting their lives and what can be done to improve the situation. It's key that we use a team around us to improve their ailments and enhance function from a nutritional perspective, obviously movement therapy, maybe mindset or life coaching, and explaining to them why they can or can't do certain things and maybe for how long, all go a big way towards them moving forwards, and also keeping them really centered in all of those decision-making processes. So even if they don't have access to some of these professionals, we could introduce them or suggest and allow them to make the decisions based on the input of all of these practitioners. But it's key that we signal or show or describe knowing, maybe having an understanding of how they feel using empathy, and also active listening. So really hearing what they're saying, maybe even between their sentences, gives them some reassurance that they're with the right person. So the objectives of this next section are really about identifying pathways, organisations that are involved with low back pain, and so that we can do some really objective history taking. So we've talked about the screening forms, the documentation, and also the referral process more so with people in pain is a really key component of being an exercise professional. There are also key barriers to participation, some of which may be more emotional, some more physical, and again we can explore some of those, and they divide across red flags and yellow flags as well. And then we're going to talk about assessments that we can use for clients with low back pain. We're going to be looking at the NICE guidelines, which are a good kind of structured guidance pathway, if you like, for clients with back pain, and the key stages of change so that we can use our pain questionnaires at the appropriate times and in a relevant way. So what we're going to be able to do is hopefully know when to refer and when we can keep the client with us, and also know when it's safe to continue with certain exercises. So government policies. So while these areas can sometimes be maybe tedious for us to explore, they're really important components of our duty of care and our insurance remit. So understanding the government policies and where they come from, how they're formed, give us confidence in knowing the structures or the systems that we're involved in as our role, maybe as a low back pain specialist, if you're level 4, or whatever your specialism or expertise. So an introduction to the government policies here and where they come from in terms of the NICE guidelines. NICE stands for the National Institute Clinical Health and Clinical Excellence. And they are also linked with the National Collaborating Centre for Primary Care, as you can see on here, or the NCCPC. And it was the NICE group that commissioned the NCCPC to sort of develop the clinical guidelines that we're going to be talking about here. The centre has the experience and the expertise to develop clinical guidelines along with a group of relevant healthcare professionals from a diverse range of backgrounds actually, and also patient representatives, which is also a key component of what we want to be aware of is how they feel. Now the authorities list here may go on, but these are just some examples of national bodies that are involved in the management of low back pain, which is rife and potentially, I think, still rising. So there's potentially things not being done in the way they should, or something is still missing. So we need to really understand it, and certainly the bodies that are going to affect us. So you will have a local authority, for example, and that might be different to mine, and they may have different guidelines based on a series of influences. So these influences can change from time to time. Obviously, things are checked and looked at, modernized, and so we need to stay up to date. I would check in at least every couple of years, maybe every year, to make sure you are still up to date with these guys and any other bodies that are relevant to you, your practice, and your duty of care. Now, awareness might not be, an awareness of options might not be something that we would consider helping our participants, our clients, to understand. So it is obviously the client or patient's choice about whether they exercise or not, but be able to give them options around that may help them understand that they have alternatives that they hadn't even considered. So by identifying appropriate goals, techniques for educating people with low back pain, we can look at determining the efficacy of certain educational goals, determining the clinical outcomes, understanding and including pain, distress, and disability. For all those involved are really key. It's also defining acute, subacute, and chronic. So acute is a very sudden onset of pain. Subacute is more recent or somewhat more rapid, but chronic is really the area we're probably most interested in as movement practitioners. And this is when they've experienced pain, in this case in the lower back, for 6 weeks, more than 6 weeks or less than 12 months. And so our role in understanding where they are might be around how long have you experienced it. This comes from our great back consultation, and it's about prompting options rather than trying to coerce a client or somebody into something. So what can be done? Can they go to a workshop, clinic, group sessions? Are there ways we can promote or advertise collaborations that we are involved in? So we've got a little bit of a flow chart here from the medico-legal requirements, or the NQAF, which is another site that I strongly recommend you go and have a look at, the National Quality Assurance Framework for the exercise referral process. And you'll find this on the document listed below. So section B of the NQAF, there's a link there as well that shows you what that looks like. And you can go and see certainly the schemes, the way they've been developed, and the way they should work. Big question is always about, well, who's responsible? And this is often the case when things go wrong. And so it's really the clinician who has referred a client in terms of the scheme that is responsible for recommending physical activity or referring the client to a specific course of action. So they are really the person that's responsible. Who would be responsible if the patient or the client suffered any loss or came to harm as a consequence of this? Then it's going to depend on the course of events. There will be an inquiry or an exploration, and if it's from the guidance given by the referring clinician and the exercise practitioner has followed that guidance, then it would go back to them. If the exercise practitioner hasn't followed those guidance, then there's a chance it would fall to the exercise professional. So those responsible should follow certainly the recommendations that are set out, and understanding motivation, programming, supervision, monitoring, and making sure everything is documented about the duration, the frequency, the intensity. This is where our paperwork really is vital, and the way we take notes, write reports, and make them sort of known, obviously following guidelines in terms of protecting data. But intentional direction by the healthcare professional allows for an initial structured and supervised exercise program with a following up assessment process. The exercise referral may be judged necessary in order to increase the likelihood of safer, more effective and enjoyable experience for the client. The exercise referral may be made to influence the adherence by easing changes which sustain habitual higher activity levels. The exercise referral may incur higher costs, however, it may reduce costs later on down the line. So the recommendations we should follow are really vital. Considering who the referral opportunities are, where are they, who are they, you know, how do they practice, why would we refer to that particular individual, do we have a multidisciplinary team around us, and is the communication meaningful, documented, accurate and protected? So looking here at the NICE guidelines, and again, we've got this kind of like flow chart and you can follow it down. Again, you can go and have a look at the NICE guidelines on .gov website, but on the NQF framework or on the NICE guidelines, the NICE website as well. They'll all guide you towards these kind of frameworks so you can understand exactly how it looks in terms of the structure, and make sure we as exercise professionals follow these guidelines and are aware of them. So the consent guidelines are also about having documentation, signed documentations with dates, ensuring everything is in place. And while being human movement practitioners, this may seem tedious, it is a really, really important part of our job to ensure the client's information and consent meets the recommended guidelines as per the NQAF documentation from, I think it's 2001, and it's all received prior to you as the exercise professional prescribing or instructing exercise when it's coming from the referrer, but also then when it's going back, just making sure we are as clear with our documentations. So duty of care is a big sort of area about what we do. It should be at the forefront of everything we do so that we don't care so much that we outstep our kind of remit because we're trying to help. And so legally, how does this influence our decisions? Well, it's trying to protect both you and your clients. And it's always the referring practitioner that should seek the advice of another clinician who's experienced maybe in exercise implications, if they're unclear about the appropriateness or the referral in terms of possible contraindications. Also from us back to the referrer or the clinicians to understand exactly what is being recommended. To comply with duty of care, there's got to be a really meaningful transfer of information from the referrer to the exercise professional who will conduct the exercise intervention. That's key. We should expect that. Where the exercise professionals are concerned, the law would expect reasonable care and skill shown in minimising any potential risk for the integration of the referrers or the clinicians' methods in detail. So the National Quality Framework document will allow you to do that so that the advice is intentional, the exercise programme is within confidential boundaries, but also there's a sustained review and evaluation process. So this GDPR, there was obviously a big thing about this in the last few years. And so what we need to do is be mindful of our personal setup. And so people don't often think of it in this way. They kind of use general guidelines. So mine are going to be general, but I'm going to hopefully highlight a few things that may or may not be of a surprise to you. So the transfer of data, data collection and protection, GDPR is really important. So you've got to understand your data requirements and the threat of the mistreat to your data collection that you're responsible for, implementation policies for data security and data disposal, come on to that now, is to determine the end life priorities, the end of life of the data you have collected. So in terms of where it's collected, how drastic should the destruction process be? Do you have employees that you need to educate? Do you have staff who have a phone that you need to either provide or retrieve or delete the data or remove the SIM card, laptops, for example? Because if they're ringing a client from their own phone, they could then store that data, and that data goes out of your control. So it's really developing what's called a cradle to grave data management policy, and then regularly testing it. So just keep an eye out about where do I write, store or communicate with a client, laptop, iPad, phone, paperwork, where is it stored, who has access to it, is it locked, who knows the locking, is the key in my pocket, where is it left in the door, etc. So if the code of conduct is breached in relation to GDPR, then the client can make a complaint. Action can be taken against the person who has leaked or not got a system in place to protect that data. So we need to list all of these platforms down, have a look at the staff, your building, all of your collection of data, make sure that the initial sent form is signed, dated, and what we would do with, for example, an assessment form of a client, we might not have their name on there, we could just use a number, and then we store one single document with the name, the address, etc., and then the number that relates to all the paperwork. That's a really quick, smart, simple way to put an extra step in there to really protect client data. So thinking about your reflective journals, your case study logs, and whether you even write someone's first name, you might be okay, but certainly if they've got the first and second name there, we should be mindful of things like that. So we've also got things, as I mentioned a moment ago, just about reflective journal, and this is good practice to use a self-reflection journal. Being mindful of GDPR, we may date it and then use coding, again, client coding, rather than their names, but it allows us to self-reflect and evaluate our own practice in working with clients on a regular basis. It's a bit like doing the case studies you might do in training, where you're thinking about the good, the bad, what you want to change, what you might want to improve, action planning. So what happened, what went well, what didn't go so well, why didn't it go so well, could I do it differently, and then creating an action plan off that. It's a really productive, simple and effective way to have a plan in place and improve your practice. So barriers in terms of understanding what might limit a client to participate if they have chronic pain could be physical, could be emotional, motivational, could be about time or availability. So if we can understand the barriers, we can help remove them or even address them by putting things into place to really create awareness and allow information to get to the clients and potential clients as well, so they can understand where they can enter this model of change. So physical barriers might be things like age, injury, disability, health problems, maybe obesity. An emotional barrier could be self-conscious, shy, they don't think they can do it, or worried they might make themselves worse. Motivational barriers might be not achieving the short-term goal, they're tired, no energy or bored with their present training program. Time might be work commitments, family commitments, or that they work shifts. And availability barriers may be that they don't have facilities nearby, they can't afford it, or they don't have the appropriate clothing or footwear. So communication skills are absolutely vital working with any client, but maybe a bit more so when somebody is experiencing discomfort or pain. And so consulting skills that use a kind of a range of concepts, including motivational interviewing, layered cueing, which is progressive layers of instruction and commands, some good knowledge of the client's condition, which is where we did that research earlier, awareness of psychological states, empathy, we've talked about, professionalism for sure, and awareness of professional bodies. All of these will count towards our ability to communicate confidently and well within our remit. It's really vital to have clear and concise communications with no ambiguity from both legal and adherence standpoints, but also for a connection with the individual. So how can we practice good communication skills? How can we show them using eye contact, open posture, and expression that we're really, really listening. Well, there's a few games that you can try and play, and I'm sure there's lots of training and courses out there. You could do something like I'm doing here, where it removes, you see my hands are moving around. I'm quite a practical person, but actually what it forces me to do is to really think about how I'm verbalizing and trying to express and explain through things like spinal anatomy we looked at earlier, which is a physical thing. So in the communication game, the blind demonstration could be that with a group of your peers, so for some trainers, practitioners who understand anatomy, we blindfold one of you, you stand in the middle, and then the people around the edge, using anatomical movement, motion and vocabulary, try to get the person with the blindfold on into a position of a sport without saying the name of the sport. So they might say shoulder abduction 30 degrees, external rotation of the humerus 45 degrees, flex the wrist, elbow, sorry. And then the idea being getting them to a position of a javelin thrower. And the blindfold person has to then guess. This removes some of the luxuries we have when we're not blindfolded. Another one is the silent demo. Can you get in front of somebody and let them know what you want them to do without saying a word? So you can imagine this from the perspective of physical demonstrations. And so how can we do that? That'll be another game. 3 questions. So this is 3 questions to work out which physical ailment they have. So you've just got 3 questions, no more, to work out what their problem is. So your colleague might make one up, and then you've got 3 questions to try it out. And then the yes/no game is you can't say yes or no when asked about your professional history. So these are all fun games that we could play with our peers, maybe our family members even, to help us kind of really be forced into a corner and develop some of our communication skills. So that's on the fun basis. However, there is obviously also the serious side, and there are certainly other training schools, and I certainly do other videos around communication and our ability to do that. And it's a big part of being a teacher and an educator, is understanding how do we best use our tone of voice, use a PowerPoint, use a video, use visual demonstrations, or maybe even silence to really bring home certain points. So again, coming back to this respect of boundaries and language and communication, often things like taking blood pressure, we may overstep the mark by simply saying something not in the way we should, or the client interprets what we've said or done. Technically, that's incorrect. So we've got to be super careful. Like taking the blood pressure, we are not in a position when we've taken their blood pressure to tell them your blood pressure is high. Only the clinical practitioner who can do a series of medical tests are legally able to do that. What we can say is, I'm reading your blood pressure today and it's a little bit high today, but we're going to modify your training, or we're going to let you sit down for a little while and we'll reassess you in a few moments, just see if it's because you've been walking here or something like that. Same with an MRI scan. What we can say is, okay, that's interesting. What did your surgeon say? What we can't say is, oh, look at that disc bulge, without having being told by the radiologist or their surgeon that that's what we're looking at. And goal setting, what we can't say is, yes, I can absolutely promise you pain relief or your money back. We can't say that. It's too subjective. But what we can say is, I can teach you how to move better. If you follow the program that I'm giving you, follow all the guidelines that me and the team are going to offer you, then there's a good chance, if your discomfort is affected by your movement, then that will improve. So it's a very long-winded way of saying it, but it is technically and legally going to cover you, rather than saying, yes, I can take your pain away. Now, code of ethics is going to differ from industry to industry. So the one that I'm involved with and the exercise professionals out there amongst you should have probably heard of is the Chartered Institute for the Management of Sport and Physical Activity. And they are really the true sort of body to understand our code of ethics. So you can have a look at those. I'm going to go through it just now. But it would certainly be very smart if you're not with these guys or in a different industry like manual therapy to go and have a look at the guidelines of your accrediting body's code of ethics. But just to give you an example of CIMSPA's code of ethics, the creation of a positive and active impact on individuals who engage in sport and physical activity. The provision of high quality experiences. Working practices that encourage integrity, inclusivity, ethical behaviour and conduct within safeguarding guidelines. A commitment to the maintenance and improvement of professional practice, which is a reflective journal, and the maintenance of professional reputation of CIMSPA. So if they're going to accredit you and the qualifications you're doing as a member, then we should really support them in their reputation alongside ours. Now, epidemiology, there is a separate task sheet that we can look at that will come along with this lecture. And if you have any questions on that, please do come back to me. But some of the risk factors that are noted for people with back pain could be lack of variability of static posture. So again, we said earlier how sitting in a chair doesn't give you back pain, but actually sitting in your chair for a long period of time could actually contribute to adaptations of the soft tissue and the structures within the body. Also, your body type and weight distribution, if pregnant or overweight, is also going to change the force going through the body. That may also have an influence on force and load in the body and how you feel. Understanding lifting techniques, repetitive lifting, stressing certain areas may or may not affect how you feel, and certainly moods and emotions that may create certain positions of the body may affect how we feel. So what we're not saying here is posture causes back pain. What we're saying is it may be one of the contributing factors of the forces that are impacted on your body that go towards the tissues not being as mobile or as healthy as they could be. And then also looking at other risk factors for low back pain, we could talk about high impact, end ranges, impact loading, overuse and trauma, because a lot of these images you see here, gymnastics isn't necessarily healthy for all joints and structures if done in an excessive sense for long periods of time. And so the life of a gymnast may be short-lived in terms of the health of their joints and tissues, for example. So we're looking again here at guidelines on, again, this is down to risk factors, but certainly higher populations. This is taken from the NQAF again. So you can go and have a look through sort of your general population, low risk, medium risk, high risk, and then actually at the top it's called it's about this multi-level approach, but really that high risk population is where we need to be mindful and checking in for red flags. But this could be a guide for you. It isn't necessarily an objective way of looking at it, but that are the guidelines that are on the NQAF. So now looking into red flags. So if you haven't come across this term, a red flag by definition is a high risk. That would be in that sort of top of that pyramid, if you like, populations. So things like cancer, infection, sciatica, etc., these kind of things in here. It doesn't mean we can't work with these demographics, but it is a red flag that we should probably have checked by a clinician prior to coming to us. And ideally, best practice would be some written documentation from the referrer to say that we can exercise them. So essentially, red flags are signs and symptoms found in the client history and a clinical examination, really, that may tie a disorder to a serious pathology. Hence, the evaluation of red flags is an integral part of primary care and can never be underestimated. The term red flag was originally associated with back pain. And then you've got yellow flags. Now, yellow flags, by definition, is more of a psychosocial influencer. So examples might be obesity, smoking, age, depression, we talked about as well, jobs. And so obstacles that can be classed as yellow flags may include aspects of the way they think, feel, or behave. And some common examples might be that catastrophizing or thinking the worst that we talked a little bit about in the pain science section. So psychosocial factors are really important in terms of understanding holistic health of the individual in front of us. And if somebody's lived with low back pain for a period of time, as we said, 6 weeks to 12 months, then actually this can affect, or vice versa, if they've had mental health issues or depression may influence their back pain, then it's important we understand it a little bit. So doing a little bit of research into what psychosocial health is, psychosocial factors, and the things that contribute to the health of our mind and then our behaviour is really important to us as practitioners. And mental health is obviously a big topic, more so in the last sort of decade, and we can all have opinions based on why that is, but certainly a pain emotion chart here shows how stress, lack of flexibility, emotional support, financial worries, fear of change, having a big ego, tension or jealousy, all of these emotions can influence our pain level or our clients' pain levels. They can be a big part of our recovery. So recognizing them and using an appropriate professional or having an appropriate qualification to deal with clients with mental health concerns then is a vital part of our practice. And within occupational health, there may be specific forms that are filled out by a health or risk assessment officer. And in here, what you can see are the risk factors. So in a job where there's a load weight, lifting and carrying, hand, how far it is from the body, and you would make markings on whether they lift it, carry it, who might help, how many reps, or kind of things where there's a scoring to that occupational health measure. So how can we help? Well, we need to understand the test, and we need to understand the problem, and then we need to understand what we can do to use intervention. And cognitive behavioural therapy, I've mentioned very briefly earlier. Oh, let's have a look at what it is. So cognitive is of the mind, behaviour we know, and then therapy is about if we want to improve. So cognitive behavioural challenge therapy is about changes to the cognitive thoughts so that negative thoughts can be restructured into positive thoughts. So an example being, I used to be able to decorate my house in no time. Now I'm useless. There is just no point in doing it. Could be changed to, if I get some help with heavy bits, I could do this decorating in chunks of an hour or half an hour, and it may take me longer, but it means I will have done it without having to rely on others. Real key component to healthy mindset and future change. So here we're looking at complementary therapy, and this it was set out by the House of Lords Select Committee in 2000. It was defined by Cochrane collaboration. You can have a look at the website as a broad domain of the health systems, modalities, and practices, and there are accompanying theories and beliefs other than those intrinsic to the politically dominant health systems of a particular society or culture in a given historical period. And there's a listing of 3 main groups. So group 1, osteopathy, acupuncture, chiropractic, herbal medicine, and homeopathy, and so on. And some of these, iridology, I believe, is to do with the colouring of the iris, may be quite shocking or a bit controversial in terms of being listed here. And yet, complementary therapy can help some people. So we should maybe stay a little open-minded to, if it helps, fantastic, and sometimes our clients can be of a certain maybe disbelief in certain areas, but some in others they hold strong beliefs, and that alone can empower them towards a healthier recovery. So if we consider what evaluation and monitoring tools we've got, and in terms of pyramid of expectation and the way we monitor, we can use our Linksman or our screening forms or documentations or reflective journals to really measure the pathway, writing down our thoughts, the dates, obviously assessment details, so that we can then start to look at our practice of monitoring and seeing improvement over time. It gives us the ability to provide evidence of our input offering improvement, and where there is no improvement, that we took action to take advantage of our peers or another professional. I think it's also key right up front with a client in one of our evaluation tools to use something like the example here, the pyramid of expectation, so that we can set up an appropriate level of expectation in the beginning. And a client coming to us with back pain and asking us to help them get rid of it is a really good example. So what we probably don't want is their goal to be no back pain. Clearly that is the goal, but that's a goal we cannot promise with any confidence, clarity, or objectivity. It's a subjective goal. So what we might want to do with our communication skills, our motivational interviewing, is really help the client to almost transition that goal into, what does the low back pain stop you doing physically? So the fit for purpose goal might be, I would like to ride my horse. And so if the back pain is stopping them riding the horse or getting out of bed or playing with the kids, then the physical act of riding the horse becomes the goal rather than the pain reduction. So there are several reasons why we would want to do this using these representation tools and maybe writing this down. We would write down maybe about their back pain, the numerical scores they put on it, the quality, the sensation, what makes it better, all of that information, so that the client feels heard. But if we also then write the act of wanting to ride the horse, what that means, is that over a certain distance, is it a particular horse of a certain hand height, is it to do dressage, to compete, or just certain trots rather than gallops or canters, and I don't ride a horse, but some of those things, for example. And then what might happen is you find that you actually succeed in helping the client ride the horse, even though they have some mild back pain while they do that, but they can do that happily and successfully. And you could potentially show them that with your evaluation pyramid of expectation, that you have contributed to them actually achieving the goal you had set out to achieve or help them achieve with you. Or another issue that we can have, if we keep pain as the goal and the pain disappears quite quickly, that still doesn't mean they're fit for purpose in terms of our pyramid. So if we've prepared them and the pain dissipates, fantastic. But we've got to then layer on a stable, strong, robust, fully functioning, or hopefully fully functioning body that might take more time than the pain reduction. And so there's a couple of ways of looking at it, but I think it's a key component. And one thing that's going to help us do this is a SMART goal. Now, very often people recognize this in all sorts of industries, and I know it is definitely a part of an exercise professional's training right back in sort of level 2, level 3. But I do believe it often gets missed over time, maybe getting complacent. And yet it enables us to have a point of reference at the point when we've succeeded in helping them achieve that specific goal. So making it specific and measurable, achievable, realistic, and timely allows us to make sure that the level of expectation over time, for example, they want to run a marathon tomorrow, is clearly not realistic or of a certain time frame. You know, if you want to run it next year, okay, maybe we can talk about that. So it allows us to agree a contract, if you like, of agreement of what the goal is going to be like, so that both the client and us, the human movement practitioner, and anybody else involved has a very clear set of parameters that are measurable and that we all feel are achievable from the outset. So smart goaling is so important. So please make sure that you have the acronym SMART written out on your consultation form so that it doesn't get missed and replaced with client has niggles, or you know, they just want to move better, or what does that mean? So really get into that nitty gritty. It will help you and them feel confident about where you are and where you're going. So we talked earlier about what if they get worse during your care, and I think just to come back to that in terms of the monitoring and evaluating, something to be aware of is, you remember the slide in the pain section where we talked about the road to recovery can be very higgledy-piggledy. It won't necessarily be a straight line of recovery. So if they get worse, what we need to do is run through certain questions to understand the pathway we recommend for the individual. So it may be that they just climbed Ben Nevis one day and they came out and they're really sore and their measurements are really regressed, and how they feel. They're trying to understand why they feel so achy, and you have to explain it, and it all makes sense. There's no red flags. It's just they need a day off, a couple of days off maybe after that. If it's something that really is starting to point towards a red or yellow flag, or something that you think, well, this doesn't quite seem right, then we need to look at the pathways that we've got set up around us. So the monitoring of how they feel, while subjective, is important to understand whether they're progressing, regressing, or whether it's just this fluctuation of recovery. So for the exercise professional working with a chronic low back pain client, planning a safe and effective workout and understanding the environment, using tools like pain questionnaires, monitoring their progress is really an important way to work with good practice and under the guidelines of what needs to be considered. So the National Evidence-Based Guidelines will consider this as a way to tailor a structured exercise program. It should be comprised of a maximum of 8 sessions over a period of 12 weeks. A group exercise has not been proven to be any less effective than groups or one-to-one observed, and so it depends on what is suitable for each individual person. So it could be group, could be one-to-one, or it could be a combination of the two. They also use the motivational model of change designed by these guys in 1983. I won't try and pronounce the first name, Prochaska and de Clement. So you can go and have a look at those. And the idea of pre-contemplation, contemplation, determination, action, relapse and maintenance, and they could exit or re-enter potentially at any stage. So it does depend on where your client is. If they've come to see you, then there's a chance they're in contemplation, they've made the decision, rather than pre-contemplation where they're not quite ready yet. But we mustn't force a client into anything or coerce them. It's about encouragement, support, guidance, signposting, educating, and offering them information so that we can then develop our skills in understanding when they might be ready in one of these phases, particularly the contemplation phase. So we should only provide support and information, and persuasion really isn't encouragement. Persuasion, again, there may be a fine line here, but they need to be ready. Otherwise, there can be a real negative effect if we really try and get them going and they're not ready for it and they slip back. They could take that quite badly. So that's sort of seen as maybe not really the ideal. So the next slide is about a task I would like you to go through, and you could do this yourself, you could do it with your peers, where you're going to create a case study example, and you're going to add any information you wish to your case study, create the story. So developing a character based on maybe somebody you know, obviously leave out their real name, decide on their personality if they adhere to the program, whether it works or whether they were challenging, plan it progressively over around about 8 weeks, make notes of your justifications to why you used which skills, when you referred, listing the barriers and the problems you faced and how you dealt with those, and then your justifications for those. Listing the great aspects of programming with justifications, and then justify every action you take, so that if you were questioned around it by another professional or by a court of law, then you could explain your thoughts with reasoning from the documentation. So every result should be based on a set of decisions that you have laid out. Good or bad, can you explain your actions? So you can pause the video and I'll let you go and practice that case study. So just to bring this lecture to a close, I'd like to talk to you about the support you can get from Biomechanics Education, but also the intrinsic Biomechanics Association and the membership. So we are involved, Biomechanics Education, on Facebook. We have a website. We're on LinkedIn, Twitter, Instagram, and we are doing everything we can to really expose the profession known as Biomechanics Coaching, which is our flagship education program, and obviously the I Move Freely program that goes along with that. So if you want to become a biomechanics coach, then obviously you can look at the website, biomechanicseducation.com. If you want to find a biomechanics coach, then we do have a map on our website where you can go and have a look in the contacts page, all those qualified biomechanics coaches who are also IBA members, so they're registered biomechanics coaches. And you can find them on there, and you can go on there as well if you gain your diploma in biomechanics coaching and become an IBA member. We've also managed to secure the term biomechanics coach within the terms and conditions in the Greybrook Insurance Brokers Limited insurance policy. So we're not saying you have to work with those guys. However, if you do become a biomechanics coach and you want that skill set recognizing, they are very familiar with us, the way we practice and the safety aspect of what we do. There are a whole series of interviews with biomechanics coaches on the YouTube channel if you want to go and have a look there, and you can see what those guys are talking about in terms of their experience running through the training and then with clients and in their business. And we run blogs, articles, a lot of videos, certainly through Instagram, photographs, to help educate, motivate, and offer you guys some support in improving the movement of the nation. We run annual events, IBA workshops, and our big event, the Kaizen Project, is all about bringing in the best of the best out there to bring you high quality sessions and education and information that is applicable straight away. So let's just have a look at this membership that is available to you, and it is on a monthly basis of £36, but within that you'll get 4 free face-to-face workshops, which are networking events, and we always cover business, technical and practical discussions based on whatever you want. They average around about 4 to 6 hours, and we run them around the UK at various locations. We've also kind of linked in with the Sports Therapy Association to bring in more lectures and of more interest across different skill sets and concepts. This membership gives free access to anybody who is a biomechanics coach to the Biomechanics Coach training camp. Obviously, you get full support from me as your master trainer, and you would get £150 worth of education, or a voucher if you like, to spend within the academy with your membership. You get a free branded t-shirt every year, and that is going to be branded with, depending on your level of training with us, or you can get your I Move Freely branding on there if not. Eligibility to the IBA Register of Biomechanics Coaches, which I talked about earlier, and for the Find a Biomechanics Coach location map, which I mentioned as well. You'll get a free business support with Chris Wright HQ, who's a fantastic motivator and technician when it comes to putting your business through ClickFunnels on social media, writing blogs and articles, and you can use his service after that ad hoc or on a subscription basis as well, but he'll give you a 40-minute over the phone consultation. You get priority access to discounts for Biomechanics education events like the Kaizen Project, and also discounts with partners like Pulse Roll, BTN Academy, and the Movement Therapy Clinics, or Movement Therapy Education, he's now known as, and also the Wolverson Fitness Equipment, along with the flowing mats as well. They're not on there, but there's an extra one for you. It's on the website. And full free access to our brand new online portal. And we are constantly filling that with more videos, resources, online courses, and IBA members will get access to that as well. And obviously there's that eligibility for accessing the insurance package with the Biomechanics coach written into the terms and conditions. So if you're wondering about the language that I've been using about I Move Freely and Biomechanics coaching, I Move Freely is a series of exercises that can be delivered either one-to-one or in a group environment. Biomechanics coaches are trained in the ability to assess the pelvis, spine, shoulder, knee and foot, muscles, bones and nerves to get a really good overview of which I Move Freely techniques might be helpful to the individual they've assessed. And both of these terms allow us to refer or charge different brackets, so low cost in the group or high-end cost in the one-to-one, but there's a common theme throughout. So if you want to know more about that, then you can get hold of us at info@biomechanics.com. But please do let us know what you think, and if you have a moment, it would be really wonderful if you ping an email over to info@biomechanics.com telling us what you think. So what made you sign up for this particular lecture? What are the benefits you feel you've gained from watching it? What is the thing you like best about it? I suppose I should put the caveat in there, is what could we do to improve it? But certainly let us know what you think, and hopefully I'll see you in another lecture.